হোয়াট ইজ লভসেট ম্যানুভার, এটা জিজ্ঞেস করা হয়। আরেকটা জিজ্ঞেস করা হয় হোয়াট ইজ বার্ন মার্শাল টেকনিক, বার্ন মার্শাল টেকনিক। তিনটা জিনিস জিজ্ঞেস করা হয়, যাকে জিজ্ঞেস করা হবে এটা জানো কি না। আচ্ছা, আমাদের একটা আইডিয়া করার জন্য আমরা বলি যে ব্রিচের সঙ্গে ভার্টেক্সের ডিফারেন্সটা কি। এখানে দেখো, যখন ডেলিভারি ইজ অকারিং লাইক দিস ওয়ে, প্রথমে একটা হেড হার্ড পার্ট, গ্র্যাজুয়ালি সফট পার্ট। সো ইফ হার্ড পার্ট পাসেস, নো ডিফিকাল্টি ইন পাসিং দ্য সফট পার্ট। কিন্তু ব্রিচে কিন্তু ইট ইজ রিভার্স। ইফ the soft part passes, that does not mean hard part will be able to pass. Number one, difficulties. Number two, when it is passing like this, you see umbilical cord is out, so it is compressed between the pelvic wall and the fetus, so fetal circulation is stopped. So only 3 minutes time is there which the brain can withstand hypoxia. So within 3 minutes after is delivered up to the umbilicus, you will get 3 minutes time to deliver the baby. If it is delayed, so baby may die, or it will suffer from irreversible hypoxic damage of the brain. Second difference. Difference number 3 is, see, when this is coming down, so because of the resistance phase coming, because of the resistance face by the fetus, so it is flexed. It is flexed. But so flexion promotes descent, reduction of the diameter, passing diameter. So that is very favorable situation. But when it is passing like this, so it is not facing any resistance. Not only that neck is there, so there is no resistance there because fundus is at that level and head is below this, so no uterine contraction is working. So it is the weight of the baby which only can promote flexion and everything. So that is very important. So if somebody pull the fetus, it will be like this. If it is extended, it will be arrested. So it is a principle, never pull from below, always push from above. So above. So if you push like this, so you should see, if you push like this, flexion will be promoted, which helps in this delivery. These are the differences. Coming to the mechanism, you see, during the mechanism we need 3 points. One is denominator, one is leading pole which touches the pelvic floor, that you have got idea already. One is denominator, which comes in relation to the different parts of the pelvis. So by that we determine what is the situation, whether it is rotating or not. And a leading pole which touches the pelvic floor, that determines in which side it will rotate. So the leading pole touches the anteriorly, it will go anterior. If it touches posteriorly, it will have long rotation, or it may go posteriorly, either one will occur. So, and number 3 is engaging diameter. So in case of it was suboccipitobregmatic, but here it is bitrochanteric. It is 10 centimeter like that. It was 9.5, slightly bigger diameter. Shoulder is also more than that, 11 like that or 12 like that. So only thing, by compression it can pass through. So bigger diameter is passing, needs passing during this delivery. So these are the problem with the basal way. That's why because of the problem of hypoxia, because of the time is less with baby delivery, so always there is chance of asphyxiated baby during this delivery. So pediatrician is a must. Pediatrician is a must. Whenever you find a breech, call the pediatricians. You know that baby may be asphyxiated. Number 2, because during delivery you need some manipulation to deliver the baby. So that manipulation cannot be done without anesthesia. So anesthetist is a must. So pediatrician and anesthetist is a must for breech delivery in labor room. So labor room, anesthetist and pediatrician must be called for during breech delivery. So now come to the mechanism. So what is denominator here in breech delivery? Sacrum. Tip of the coccyx, you can say, or fifth sacral vertebra. Coccyx is malleable, you can say fifth sacral. So this is the denominator. This is not the leading pole. This will not touch the coming. One is anterior and one is posterior. So, so either anterior buttock or the posterior buttock. Some buttock will touch the pelvic floor. And accordingly, if the anterior buttock touches the pelvic floor, rotation will be like this. And if the posterior buttock touches, it will not be like that. So always the dependent part or leading pole is the anterior buttock. So that is during the mechanism it will come into play. So one is sacrum is the denominator, bisacromial bitrochanteric diameter of the is the engaging diameter of the breech, and leading pole either anterior buttock or posterior. Most of the cases it is anterior buttock. So and number 3, during delivery of the fetus by cephalic presentation, we are concerned with the delivery of the head. But here, after delivery of the buttock, after delivery of the shoulder, these are the soft part, then delivery of the head comes, which is called aftercoming head. It is called aftercoming head because it is coming after that. It is coming after coming head. So this will come. So gradually harder parts, larger diameter and harder parts are coming, and not only that, the chance of flexion is less here because there is no resistance faced by the head. So now we come to the mechanism. So if I say the sacrum is the denominator, so if it is like this, so left sacro-anterior. This one is left, this one is right. So sacrum lying against the iliopubic eminence, left sacro-anterior. So who is touching? Anterior buttock is touching the opposite pelvic floor. Left is the denominator, but this is on the opposite pelvic floor. Then if it touches the pelvic floor, it will rotate like this till the bitrochanteric diameter comes along the anterior posterior diameter of the pelvis. Then it will descend further with the uterine contraction. Then see till the anterior buttocks comes under the symphysis pubis as occurs in the cephalic presentation. Then hinging against the symphysis pubis, inferior border symphysis pubis, there will be lateral flexion. So after the posterior buttock is delivered, anterior buttock will be fall from under the symphysis pubis. So buttock is delivered. Then you see the shoulder, by the time buttock is delivered, shoulder is, so it was like this. So shoulder will engage in the same oblique diameter. Again rotation, again it will be delivered after the anterior shoulder hinges, posterior shoulder delivered, the anterior shoulder delivered. So breech will be like this. After it is born up to here, up to the abdomen. So shoulder is delivered. When the shoulder is delivered, you see scapula will be visible. You will be able to see the scapula, and you will be, if the baby is like this, the arms are flexed over the chest, then either you will be able to feel the arm in front of the chest. If you cannot feel the arm in front of the chest, that means arm is extended. That means arm is extended means like this. So greater diameter will face during delivery of the aftercoming head. So it will cause arrest of the shoulder. So extended arm is the cause of arrest of the shoulder delivery, arrest of the shoulder. And you see, after this is delivered, then you see, after it is delivered, then unless you see the head, if this is like this, so how the head is engaging? See, along the transverse diameter. because it is the available greatest diameter in the pelvis. So head will always try to avail that diameter. And because it is not well flexed, because it is not facing the resistance, slightly extended head. So it will not be the suboccipitobregmatic, it will be occipitobregmatic. This is a higher diameter, longer diameter. So longer diameter will try to accommodate transverse plane. So again, you see, if it is flexed, then what will happen? What is the leading pole? Is it the vertex or it is the chin? The chin. So chin will touch the pelvic floor. If the chin touches the pelvic floor, then according to law of pelvic floor, the chin will rotate higher anteriorly. So it will be like this. So what happens? Baby becomes extended against larger diameter. So it is, baby will not be, if it happens, that means baby will not be delivered. After coming head will be arrested because it is extended like this. So it have to flex. So this does not happen. Why it does not happen? Because this rotation cannot happen because of the weight of the fetus. It prevents the anterior rotation. So always there will be posterior rotation. So always you find the back will face towards the acquisition. So always our aim is to keep the back in front in case of breech delivery. So, and that in that way, if you allow the baby to hang, so what is the force? Number one is the weight of the baby, and number two, you see fundus is at that level, so fundal pressure cannot occur. So only the suprapubic pressure, if you put your hand there, you can flex the head. So that will promote. We ask the one assistant will be needed for breech delivery. So what are the things needed? One assistant, one anesthetist, one pediatrician. That is a must. So you flex the head and gradually with the weight of the baby, when the hairline is visible, that means the subocciput has come under the symphysis pubis. Then you pull the baby like this. Hold the baby by the ankle. You can wrap the baby by some towel, hold the baby ankle, and gradually you lift the baby with a little traction. You lift the baby, no more traction. Lift the baby, so the baby will be delivered. So baby is delivering in which way? How the vertex is delivered? By flexion or by extension? By extension. But here the baby will be delivered by flexion. So first the chin is delivered, then is the begma, then is the occiput. This will occur. So that is the mechanism of labor, breech delivery. Now you come to the management. Management, I have said three things. So here three things are important: delivery of the buttock, then delivery of the shoulder, then delivery of the aftercoming head. So if you find, so you see, in case of cephalic presentation, you can, if the head passes the pelvic brim, you know there is no pelvic contraction. But in case of breech delivery, that assessment, scope of that assessment is not there. So if you fail to assess the pelvis, the aftercoming head will face the contracted outlet, it will not be delivered. Baby will die, simply. So that's why very important, especially in primary gravida, assessing the pelvis before allowing the vaginal breech delivery. Assessment. So in case of multigravida, who have a vaginal birth before, in that case, breech delivery is ideal. But in case of primary gravida, if you face the breech presentation, then always you keep your mind that assessment of the pelvis is not being done satisfactorily. So you can assess it by your clinical pelvimetry, but still that may be inadequate. So that situation may be faced. So ideal situation for breech delivery is second gravida, third gravida, like that. So no need of doing cesarean section. So always there. But in case of primary gravida, always you think of, especially because cause of malpresentation, if you go through, one of the cause is contracted pelvis, which is preventing the engagement of the head. So there is breech presentation, there is shoulder presentation. If the low-lying placenta, it will prevent the engagement of the head, will be placenta previa will be associated with breech. So whenever you face the breech presentation, first thing you suspect whether that is a contract, especially in primary, whether this is a contracted pelvis or not. Next thing, whether this is placenta previa or not. And third thing is, you see, baby always changes its position up to 36 weeks. After 36 weeks, it becomes fixed. So multi-capital still is there. So if it is a preterm breech, preterm labor, always suspect whether it is breech presentation, because always changing, like 2 days back it was cephalic, this day it may be breech. So always premature birth may be associated with breech presentation. Breech presentation with prematurity. Prematurity is one of the causes of the breech presentation. So these are the causes of breech presentation. Now, what we are coming to the management, that means delivery of the buttock first. So whenever some patients are coming and assess that it is a breech. How do you assess it is a breech? Because the hard parts are felt. You get the soft parts, that means toe contour. If it is a flexed breech, that means you get the fingers. Fingers means the flexed breech. This is a extended breech. So which is favorable for delivery, flexed or extended? Always, because the circumference is less, it will engage, but during delivery it will prevent the movement of the breech. So this is not a good breech. Not only number one, number two, you see that cord is here. If it is a flexed breech, and because it is not fitting well with the lower segment, always there is chance of cord prolapse. So whenever you get the breech presentation, you have to search for the cord. If it is a cord, then you have to take care whether what all you do the cesarean section or do the rapid delivery of the breech. If it is os is not dilated, you have to go for cesarean section, because there is always chance of cord prolapse. So that is another cause of high mortality in patient. In breech presentation, mortality is 3 times more than the cephalic presentation. These are the reasons. Number one, cord prolapse. Number two, during the manipulation, fetal hypoxia. Number 3, there may be prematurity. Prematurity also, the engagement is not there. So always there is rupture of membrane, and premature rupture of membrane can occur because the head is fitting well to the pelvis, but breech is not fitting well. So always there is forewater is more, so there is rupture of membrane. So whenever there is rupture of membrane, you have to see whether you are dealing with a case of breech presentation. So breech presentation is associated with so many things: premature rupture of membrane, prematurity, placenta previa, contracted pelvis. So many things you have to judge whether which one is present with the breech presentation. So cord prolapse, chance of cord prolapse. So you see, if the membrane is not ruptured, and so allow the labor to progress, and you assess how it is progressing. You can, if the contraction is not good, if your assessment that there is no quick contraction, you can allow syntocinon drip for more contraction, and till the breech is distending the perineum. Like the head distends the vulva, that means crowning. This is called climbing the perineum. In case of head, it is called crowning, but in case of breech, it is called climbing the perineum. So perineum is distended, and you have to do episiotomy in all cases. So episiotomy is a must in case of breech presentation, because the aftercoming head, this is not for the delivery of the buttock, delivery of the aftercoming head, because time is less. So the head will come, it will distend the perineum, then it will be delivered. No. So head will come so that head can be delivered easily, or if some manipulation is needed, you can do it if episiotomy is done. And it is called liberal episiotomy. Not only episiotomy, it will be called liberal episiotomy for breech presentation. So, till the baby is distending the vulva, you do the episiotomy, and you allow the patient is with the bearing down efforts, the if the breech is flexed breech, if it is a flexed breech, you can get the foot. So if it is felt, you can easily deliver it. So the rest of the baby easily delivered. And then up to the umbilicus, so after the up to umbilicus delivery or beyond the umbilicus, a cord pulsation will go because of the pressure from the pelvic wall with the fetus. Cord pulsation will go, and then the delivery of the shoulder comes. So this is the time. So you have to search for the again hands in front of the chest. If it is hand in front of the chest, then it is good. So you can easily by pressure on the ankle, you can release the arm. So baby is delivered. Baby is delivered, shoulder, and then so step 1 is episiotomy. Step 2 is release of the arm, and step 3 is you allow the baby deliver and hang, and ask the assistant to put suprapubic pressure for flexion, promoting flexion. And when step 3 is this, when till the hairline is visible, and this is the by covering the baby with the sterile towel, holding the ankle, gradually you will lift the baby up with a wide arc. If you do like this before the hairline is visible, you do like this, there will be injury at the neck, so baby will die. So only by this time, this will be delivered by flexion like this, So this is called assisted breech delivery. Step 1, step 2, step 3. Right, assisted breech delivery. This is asked, what is assisted breech delivery? I repeat again, episiotomy for delivery of the buttock, release your legs. If it is flexed, if it is not flexed, no problem, you cannot do anything. So you further descent, it will come down, and till up to the abdomen is delivered, and at that time you have to search for the arms in front of the chest, and if you see the scapula, if they are parallel, that means flexed arm. If there is not parallel, the winged scapula, that means it is extended arm, there will be difficulty in delivering the shoulder. What measures will be taken, we are coming to that, but if you release the arm, it will come down, and then you hang the baby, and whenever this is, and put the pressure, when this is visible, then you deliver by Burn Marshall method. This is the assisted breech delivery. Then, what is breech extraction then? That is asked often. What is breech extraction? Breech extraction means hurried delivery of the breech. Suppose cord prolapse, dilated, you just pull the baby, and always you ask the assistant to put suprapubic pressure so that it is not extended. So whenever you will pull, so there is chance of extension. So same procedure you have to follow, but quickly the delivery of the baby. So that is called breech extraction. So either there is fetal distress or there is cord prolapse. These are the situations where you have to go for breech extraction. Or second baby of twin, you can go for small baby. So it will come down, and as quickly you deliver, the better will be the prognosis. In that case, you do it. So that is what is breech extraction. Number 3, I have told that what is Loveset maneuver. Loveset maneuver. This is a maneuver for delivery of the shoulder, which is arrested. After delivery, up to the umbilicus, there is no further progress. So no further progress, and especially where you cannot find the arms in front of the chest, likely the arm is extended, or the shoulder may be bigger, because of that it is not descending further. So in that case, you see, pelvis is anteriorly deficient. So if some parts you want to deliver, you have to deliver anteriorly. Posteriorly it is long, you will not be able to deliver it. That's why we get the advantage of this architecture, this design. So whenever this shoulder, suppose shoulder is arrested here like this, arrested here. So if you see, if in this way, so what is this? Posterior shoulder is lying at a higher level, and anterior shoulder is there. So that's why not progressing. So if you do like this, what happens? Posterior shoulder comes low. Then if you rotate, what will happen? It will release under the symphysis pubis. So slight lifting of the baby, followed by 180-degree rotation, keeping the back anterior. এরকম rotate করলে হবে না, extension হয়ে যাবে, baby delivery হবে না. Always principle is to keep the back in front. So this is then after the posterior shoulder becomes anterior delivered, then again you rotate like this. Again the which was posterior becomes anterior. So whenever there is arrest of shoulder, this maneuver is called Loveset maneuver. Usually this is done under anesthesia, but in our days we have no anesthesia available. We have to practice the Loveset like this, and it is very easy thing. You can easily, you hold the baby where? Not over the abdomen, visceral will be damaged. You hold the baby by the buttock, and you rotate like this, or you rotate like this. So this is called maneuver, delivery of the arrest of the shoulder. Then comes delivery of the aftercoming head. If the head is large, or especially if the head is not, if the flexion is not maintained, head is extended, so it will not be delivered through greater diameter, occipitofrontal. In case of occipitobregmatic, occipitofrontal diameter, which is larger diameter, is coming. Usually suboccipitobregmatic or occipitobregmatic. Then if it is occipitofrontal, further large diameter, so it will not be able to negotiate through the pelvis. So in that case, because of the extended head, so you have to make the head flexed. How to do it? That is called Jaw-Flexion-Shoulder-Traction. Jaw-Flexion-Shoulder-Traction. You put the baby in your left hand like this, and you put your two fingers on the shoulder and keep the middle finger on the head. So this will not be possible unless the patient is under anesthesia. So baby ache, with that your two finger is negotiating, so much of space will not be available. Patient will go into shock. So you have to pull the baby by jaw, and you have to, at the same time, you have to try to make it flexed, and this two finger will be on your malar prominence. Not of the jaw will be dislocated, malar prominence. In that way it will be flexed, and in that way you can come. Whenever this part is coming, then you are pulling like that. This is called Jaw-Flexion-Shoulder-Traction. এর আরেকটা নাম আছে Marcel Maurice Vatt, like that. So this is the maneuver for arrest of the aftercoming head. So that is number. Acha. And so what remains is the arrest of the buttock. Arrest of the buttock. Suppose breech has come to the perineum, but there is no further progress. Likely cause is this extended leg. Extended leg, because we have flexed leg, you can release but because it is not allowing the baby movement because of the, so in that case, In that case, usually, if you are putting definitely your episiotomy, then either you can do some traction by the anterior groin, and traction will be towards the trunk, not towards the femur. Then it will cause fracture of the femur. It will be towards the trunk, so it will be gradually come. Okay? And that is the episiotomy. You are putting Sintor drip, and you have to, when it will come like that, then you can deliver it. Or sometimes if it is possible, that is very difficult, you have to put, if it is high up, you can tap the popliteal fossa. So this limb will be flexed. When it is flexed, you can take it out. Then you can do it on. That is called Peanuts maneuver. Peanuts maneuver. So that is the management of arrest of the buttock at the perineum. If it is further high, so you can go for breech extraction. But breech extraction is always, you have to think of if there is further, because you are doing delivering the breech quickly, there is always chance of extension. Always better to do it under anesthesia. So that is about the breech extension. Some other maneuvers are there. We are not going to that. Very difficult maneuver. Suppose if the as you are saying that always you keep the baby anterior, but somebody has done something that it has become like that, front is anterior. So in that case, it is very difficult to maneuver this thing in this position. Maneuver that is called Prax maneuver, like that. I cannot now remember, but that manipulation is there. So in case of breech presentation, what is the first thing? First thing is to make the breech cephalic presentation. So that sort of maneuver is not needed. So for making that, what we do? External cephalic version, and that is done at 35 up to 36 weeks, not beyond that, 35, 36. Because if you do it before that, if the liker is good, then you will be successful in external cephalic version. But chance is again their reversion. So if you do it late, then the chance will be, reverse chance of reversion will be less. So that is a possibility, that is a measure to reduce breech delivery. And see breech delivery, whenever somebody sees such sort of manipulations in the on delivery room or not, so always C-N section is a option. Some of them like. So that is the external cephalic version. So that contraindications where you will not be able to do. In case of APH, you will not be able to do. In case of IUGR, you will not be able to do. Or if it is a post-cesarean pregnancy, because the chance of scar rupture will be there. And external cephalic version, always, if during rotation, if the cord entangled in some way, so will be fetal distress. So if you hear the fetal sound before doing it, and after you are successful, you again hear the fetal sound. If there is, that's the reason for doing it 36 weeks. If you face some difficulties, suppose cord prolapse, suppose your accidental hemorrhage, suppose your fetal distress, you can always do C-N section. So breech presentation itself merits C-N section. So during your version, if you face some complication, because you are doing it at 35, 36 weeks, the baby is mature, so C-N section is not harmful to the mother. That's why you do it near just 36 weeks like that. So the external cephalic version, role of external cephalic version in Breech presentation, or it is given in তোমাদের তো এগুলো থাকবে পরে আর থাকবে না justification, justify external cephalic version in Breech presentation. So কোন কোন কন্ডিশনে করা যাবে, কোন কোন কন্ডিশনে করা যাবে না সেটা we have to tell. So তাহলে আমাদের Breech presentation এ routine delivery of the head in Breech presentation, what I have said, it is Burn-Marshall technique. That is incarceration. Sometimes somebody does not wait for the Burn-Marshall technique. They want the control deliver the head by forceps. That is specially designed forceps, very light forceps, which can be easily negotiated in the pelvis, that is bypass forceps. But for the forceps deliver the head must be in the pelvic cavity. Higher head will not be able to deliver by forceps. Always in that case, Jaw-Flexion-Shoulder-Traction is the method. So somebody does routine delivery of the head by forceps. It is also applicable, suppose Breech presentation you are going for cesarean section. In that case, these manipulation for assistant delivery which I have said, that is also applicable there. That manipulation in that way, rotation, then during delivery of the head, that you have to put fundal pressures. If the breech head is extended during delivery through the cesarean scar, it will be arrested. And if you pull it like that, then there will be damage to the neck. So these manipulations are very, very important even you go for cesarean section during Breech presentation. And causes of Breech presentation, as I have said, all those things, contracted pelvis, placenta previa, prematurity, all those things. Besides that, very important is to exclude hydrocephalus. So hydrocephalus, head is not engaged, big head is preventing its engagement, so it becomes Breech presentation. So in all the cases of Breech presentation, we must exclude hydrocephalus, we must exclude placenta previa, we must exclude contracted pelvis, right? And because usually a mechanism will not be asked, but it will be asked the management part. So management is either Loveset or Burn-Marshall or Jaw-Flexion, either of these three, right? ঠিক আছে, এটা তোমরা একটু পড়ে নাও, আর পরে যদি আরো কিছু জিজ্ঞেস করতে থাকে জিজ্ঞেস করবে। আর অ্যারেস্ট অফ দি ব্রিচ সব ক্ষেত্রেই অ্যারেস্ট অফ দি ব্রিচ অ্যাট দি পেরিনিয়াম আর অ্যাবাভ দি পেরিনিয়াম হতে পারে। অ্যান্ড hydrocephalus you have to keep in mind, because if it is hydrocephalus and baby's body is delivered no other way. If during your manipulation the baby becomes dead, what will you do? Especially if you find somebody else come, oh, this is a hydrocephalus baby. So you have to do the destructive operation. That means craniotomy. And suppose hydrocephalus with Breech presentation has come to you, and you are seeing the hydrocephalus. So at suppose 34 weeks, 32 weeks, so what will you do? So even if you do cesarean section, that head cannot be delivered. So you have to do the craniotomy, that you have to decompress the head. So that can be done parabdominally and parvaginally, and that can be done also. You can do it parvaginally, you can do it through the spine. Some catheter, if you pass through the spine, and if you pass it, the whole fluid will be delivered, head will be compressed and breech will easily come down. These are the management for breech with dead baby. That will also happen. এই যেটা বললাম পড়ে নাও, পরে আবার হলে জিজ্ঞেস করবে। আজকে একটা ভালো ওটি ছিল, যার জন্য আমরা একটু ছিলাম। কেস ওয়াজে তোমাদের জিজ্ঞেস করেছিলাম, এই তুমি আর মাঝে একবার আসবে, যেখানে যেখানে তোমাদের আর মনে থাকবে না, কিন্তু যেখানে যেখানে তোমাদের গ্যাপগুলো হয়েছে সেগুলো আমরা করে দেবো, মেকআপ করে দেবো। কেসটা ছিল 18 ইয়ার্স গার্ল, আমি যে ওটিতে ছিল, এই এসেছে 18 ইয়ার্স গার্ল, পেন অ্যাবডোমেন, কেম, USG done, 10 centimeter lump. So everybody will diagnose that this is a case of twisted ovarian cyst. One sided ovary is normal, other sided ovary is not found, and that is instead of that mass is found. Everybody will say that. Then USG finding was like that. Then somebody does the CT scan, and CT scan said some solid, some cystic, and all those things, and right, this is a malignant ovarian mass. হয়ে গেল, ম্যালিগন্যান্সির অপারেশন করতে হবে, লিম্ফ নোড বাদ দিতে হবে, ইউট্রাস বাদ চলে যেতে হবে, and tumor markers all are okay except LDH is high. LDH কার tumor markers? Which? Dysgerminoma. Dysgerminoma, as I know, most of the cases are solid, but this is a cystic with a solid component. Always which is the most commonest ovarian tumor at the young age group? Brother, commonest ovarian tumor in the young age group? Teratoma, mature teratoma. তো ওটাই কমন আমি করবো, ওখানে ম্যালিগন্যান্সি কোনো ফিচার উই আর নট গেটিং। তো আমাদের ডায়াগনোসিস ডার্মায়েড হবে। স্টেট এক্সরে করিনি, আমি বলেছিলাম স্টেট এক্সরে করতে, কিন্তু এত তাড়াতাড়ি আমাদের কাছে আসছে যে সময় পাচ্ছে, গাদা ইনভেস্টিগেশন করছে, দেখতে দেখতে চলে যাচ্ছে। ক্যালসিফিকেশন আছে কিন্তু, তাহলে ওটা আরও পরিষ্কার হয়ে যেত, ওই ক্যালসিফিকেশনগুলো টিথ ফিট কিনা জানা হয়ে যেত। কিন্তু স্টেট এক্সরেটা করলো না, কি বেরিয়েছে স্যাম্পলটা নিশ্চয়ই রাখা থাকবে আমাদের। অ্যান্ড আলটিমেটলি এবার ইয়াং ওমেন 18 বছর, ক্লাস 12 পড়ছে, এবার তাদের তো আমরা চাই কি যে ইউজুয়ালি ইয়াং ওভারিয়ান সিস্টগুলোকে আমরা ল্যাপ্রোস্কোপিক্যালি করবো, ঠিক আছে। এবার এখানে যদি আমরা কিছু তোর মাথায় কেউ ম্যালিগন্যান্সি ঢুকিয়ে দেয়, তাহলে তো ল্যাপ্রোস্কোপি ইজ কন্ট্রাইন্ডিকেটেড। ওখানে একটু এদিক হয়ে রাপচার হয়ে গেলেই ওর স্টেজিং চেঞ্জ হয়ে যাবে। যেটা স্টেজ 1 ছিল বা বর্ডার লাইন ছিল, স্টেজ বিকাম স্টেজ 1C, স্পিল হয়ে যাবে চারিদিকে, সেটা করা যাবে না। তাহলে একদম ইনফ্রাম্বালিকাল বা এরকম ইনসিশন, লম্বা ইনসিশন দিতে হবে। তাহলে এবার ওকে কাউন্সিলিং ফাউন্সিলিং করে আলটিমেটলি ওর খারাপ, ওকে যেটা আমরা করে দিলাম, বোধহয় বিনাইনি বেরোবে, আমি চলে এসেছি, ওটিতে হয়ে গেছে, ওটা চলে এসেছি, কিন্তু ওর ওই শেষ পর্যন্ত লংজিটিউডাল, ওরা বলেছিল স্যার ওই বিনাইন বেরোবে, একটু ট্রান্সফার্স দিয়ে করে দিই। তারপরে এইসব ম্যালিগন্যান্সি ফিচার তুলেছে বলে তখন তো আর তোমায় করতে পারবে না, ফার্স্ট চান্স ম্যালিগন্যান্সি কেউ জানে না, তো ম্যালিগন্যান্সি বেরিয়ে গেলে, হ্যাঁ, যদিও দেখো আমরা টিউমার মার্কার থেকে আমরা নিশ্চিত যে ডিসজার্মিনোমা মানে কি, জার্ম সেলেরই তো টিউমার, তার তো হয় বিটা সিজি হাই হবে, নয় আলফা ফিটোপ্রোটিন হাই হবে, না হলে আরও অনেক কিছুই হাই হবে, কোনোটাই হাই নেই। এলডিএইচটা হাই, এলডিএইচটা এ থেকে হয়। তো সেখানে কোথাও কিন্তু সিটি স্ক্যানে কোথাও না কোনো মেটাস্টেসিস নেই। আমরা সিটি স্ক্যান ইউজুয়ালি করতাম না, আমার কোনোদিন সিটি স্ক্যান এমআরআই আমি করি না, ইউএসজি ইজ এনাফ, হ্যাঁ, তাতে। এবং অ্যাসাইটিসও সেরকম নেই, লিম্ফ নোড নেই বলে দিয়েছে, ওভারি লিম্ফ কোথাও পেট্রোপিনিয়ান নেই বলেছে, আর কোথায় যাবে। সিটি স্ক্যানে লিম্ফ নোড নেই বলছে মানে কি, লেস দ্যান, সিটি স্ক্যানের রেজলিউশন হচ্ছে আপ টু 2 মিলিমিটার লাইক দ্যাট, 2 to 3 মিলিমিটার পর্যন্ত লিম্ফ নোড বড় হলে সে সিটি স্ক্যানের রেজলিউশন এসে যাবে, কিন্তু 1 মিলিমিটারের নিচে এলে সেটা সিটি স্ক্যান বলতে পারবে না, মাইক্রোস্কোপিক মেটাস্টেসিস। হ্যাঁ, তো এবার হচ্ছে কোশ্চেনটা হচ্ছে, এবার এই যে ওভারিয়ান টিউমার যার কোনো নাই, ম্যালিগন্যান্সি টিউমার মার্কার নেগেটিভ, তার কি ম্যালিগন্যান্সি হতে পারে? সেটা হচ্ছে বর্ডার লাইন ম্যালিগন্যান্সি, মানে যেটা এখন এপিথেলিয়ালকে ব্রেক করেনি, সেটা তো বায়োপসি হবে। এটা আমরা যদি আমাদের এখানে ফ্রোজেন সেকশন থাকতো, তাহলে আমরা ওটিতেই আমাদের এটা বেরিয়ে যেত, এটা ম্যালিগন্যান্সি আছে কি নেই, বিনাইন কিনা, পরিষ্কার হয়ে যেত। ফ্রোজেন সেকশনটা নেই, এবার আমাদের ওয়েট করতে হবে বায়োপসি আসার পরে। যদি কোনো কারণে এরকম বর্ডার লাইনই আসে, তাহলে কিন্তু বর্ডার লাইন মানে কি, স্টেজ 1 ইউনিল্যাটারাল ইনভলভ মানে স্টেজ 1A, দুদিকের ওভারি হলে 1B, বা অন্য জায়গা হলে পেলভিস হলে 1C, ইত্যাদি ইত্যাদি। স্টেজ 1A-তে তুমি যদি সিম্পল ওভারিওটমি করো, দ্যাট ইজ দিস কমপ্লিট ট্রিটমেন্ট। এরপরে কোথাও মাইক্রোস্কোপিক ডিপোজিট থাকলে তোমার একটু ফলো আপ করতে হবে, এলডিএইচটা বেশি এসছে, এলডিএইচ দিয়ে ফলো আপ করতে হবে। আর যদি দেখা যায় যে ফলো আপে কিছু হচ্ছে না, 1 year লাইক দ্যাট, তারপরে পেশেন্টের কিওর, কিছু করতে হবে না। এই সিচুয়েশানটা আমরা ফেস করি প্রায়ই প্রেগনেন্সি ওভারিয়ান সিস্ট। ওভান সিস্ট সিআর করেছে, অথবা ওভান সিস্ট রিমুভ করে দিয়েছে, এইবারে এলো বর্ডার লাইন টিউমার। এবার সবার চিন্তা যে এপিথেলিয়াল ম্যালিগনেন্সি বর্ডার লাইন, কী করবে? কিছু কিছু করতে হয় না, ওই ফলো আপ, হ্যাঁ, এই হচ্ছে ট্রিটমেন্ট।